Hello, this is Dr. Cotty, and I'm here to talk today about schizophrenia spectrum and other psychotic disorders. The objectives. Identify schizophrenia spectrum and other psychotic disorders in the DSM-5. Summarize characteristics of schizophrenia spectrum and other psychotic disorders. List 5 domains of abnormalities found in psychiatric disorders. Differentiate between negative and positive symptoms. Overview. Psychotic disorders affect thinking, behavior, emotions, and perception of reality. It can be caused by a combination of genetic, neurobiological, and non-genetic risk factors. The typical onset is the late teens and early 20s. Diagnoses of these disorders should not be made until after the age of 7. Being diagnosed with one of these disorders could include symptoms that interfere with interpersonal relationships, self-care, and ability to work. Patients with schizophrenia or other psychotic disorders may have trouble with figuring out what is real and what is a delusion. Others might be frightened by their behaviors. They can cause disturbances in thinking, perception, emotion, and behaviors. And there is a severe deterioration of social and occupational functioning. In the United States, the lifetime prevalence of schizophrenia or schizophrenia-type disorders is about 1%. There's no single treatment for these disorders. It requires a comprehensive, multidisciplinary effort. There is no cure, but there can be remissions. Of all the mental illnesses, schizophrenia probably causes the more lengthy hospitalization, chaos in family life, and cost to people and government. It also causes a lot of fear. Only about 1/3 of the individuals who are diagnosed with these disorders achieve significant lasting improvement. 1/3 attempt suicide and 1 in 10 achieve suicide. The DSM-5 lists the following disorders under schizophrenia spectrum and other psychotic disorders: schizotypal personality disorder, delusional disorders, brief psychotic disorder, and that can be caused from stress or postpartum, schizophreniform disorder, schizophrenia, schizoaffective, bipolar type, depressed type, psychotic disorder due to another medical condition, catatonia associated with another mental disorder or a medical condition, unspecified catatonia, other specified schizophrenia spectrum and other psychotic disorder, and unspecified schizophrenia spectrum and other psychotic disorders. So that is how they are listed in the DSM-5. What? Catatonia. So what is catatonia? These individuals who are experiencing the symptom catatonia may be in a stupor, which is kind of a state of near unconsciousness, or they can't make sense of things. They may be experiencing mutism, the inability to speak. They may be experiencing negative symptoms, which we'll go over more in depth coming up, or catalepsy, which is kind of a trance, or it could be a seizure with a loss of sensation and consciousness, accompanied by rigidity of the body. When I was a floor nurse in an inpatient psychiatric ward, I was walking down the hall to give somebody their medicine. And when I came back, the patient that I had passed earlier was still standing in the exact same place looking at the bulletin board. Now, the bulletin board had very little on it. It was like a whiteboard. But the person was stuck. They were literally frozen. So that is what catatonia can look like. Here is a breakdown of kind of the differences of some of the diagnoses from a diagnostic perspective in the DSM. So in schizophrenia, to be diagnosed with that, the individual needs to have psychotic thinking or behavior present for at least 6 months with impaired functioning. In schizotypal personality disorder, there has to be impairments of personality functioning. Delusional disorder, The client experiences delusional thinking for at least 1 month. Brief psychotic disorder. The client has psychotic manifestations that last between 1 day to 1 month. Schizophreniform. Manifestations are similar to those of schizophrenia, but the duration is shorter, so 1 to 6 months. And substance-induced psychotic disorder. Psychosis is within 1 month of substance intoxication or withdrawal. So what causes schizophrenia? Well, there are some predisposing factors. Biological influences can include dopamine issues or genetic factors. So when we're talking about dopamine, hyperactivity of dopaminergic activity in the limbic part of the brain can cause hallucinations, delusional thinkings, grandiose thoughts. Hypoactivity of dopamine in the frontal region of the brain can result in the negative symptoms, so the flattening affect and lack of interest in doing things, or anhedonia. Schizophrenia runs in families with first-degree relatives at about 10%, and identical twins and children with 2 parents who have the disorder have a 50% likelihood of getting it. But 2/3 of people have no family history of schizophrenia, so where does it come from? Well, some theories are that there are physiological influences. So a viral infection, like an infant whose mom had a flu in the 2nd trimester, or anatomical abnormalities of the lateral and ventral enlargement in the brain. So what's happening in our brains when we have schizophrenia? Well, the basal ganglia is involved in movement and emotions and integrating sensory information. So abnormal functioning in schizophrenia is thought to contribute to the paranoia and hallucinations in this part of the brain. And if we block the dopamine receptors here too much with antipsychotic medications, then we have the motor side effects. The frontal lobe is critical to problem solving, insight, and other high-level reasoning. So when you have schizophrenia, this can lead to problems in planning actions, organizing thoughts. Our limbic system involves emotion. So disturbances here are thought to contribute to agitation, frequently seen in somebody with schizophrenia. The auditory system allows us to hear and understand speech. So when that area is overactive, it's called Wernicke's area, it can create auditory hallucinations, the illusion that internally generates thoughts, that there are real voices coming from the outside. The occipital lobe processes information about the visual world. So people with schizophrenia rarely have full-blown visual hallucinations, but they may have a hard time with complex images, recognizing motion, or reading emotions on someone else's face. Hippocampus, that mediates learning and memory formation, and it's intertwined with functions that are also impaired with schizophrenia. So that's what our brain is doing when we have schizophrenia. So what is the prognosis of somebody who has one of these disorders? Well, there are things that make it a more favorable outcome and things that make it a less favorable outcome. So if the individual has a late disease onset, that is more favorable than an early disease onset. Females usually have a better prognosis than male. Minimal cognitive impairment has a better prognosis than somebody that has cognitive impairment. So being paranoid with schizophrenia is better than having disorganized thinking with schizophrenia. If you have a family history of mood disorders, that is better than having a family history of schizophrenia. And remember, men are usually diagnosed with this before the age of 30 and women by about the early 30s. So earlier we mentioned that individuals may have a hard time functioning in life if they have schizophrenia. And indeed, a lot of these individuals are in disability because they have a hard time with medication compliance a hard time keeping friends or family members, sometimes a hard time keeping housing, and therefore it makes it hard to be productive members of society. However, having a diagnosis of schizophrenia does not mean that you cannot be a college professor or work in a regular job anywhere. So, of course, it takes proper medication and a good care team. But if you guys remember the movie A Beautiful Mind, John Nash was diagnosed at the age of 31. So remember, in the prognosis, it's better when you're diagnosed later. And he was a mathematician. So I think he was born in 1928. He died in 2015. And the movie A Beautiful Mind won 8 Oscars. So if you guys haven't seen it, you might enjoy doing that in your downtime this summer. The movie was based on a true story of this mathematical genius who struggled with schizophrenia. And he was often rejected by his classmates for being intellectually superior. His theories are used still in economics, computing, biology, artificial intelligence, accounting, computer science, games of skill, politics, military theory, and he was a senior research mathematician at Princeton in the later part of his life. He shared the 1994 Nobel Memorial Prize in Economic Science with a game theorist, with 2 other game theorists, and in 2015 he got the Abel Prize for work on nonlinear partial differential equations. So, in summary, he published 23 studies. He received a lot of awards. And he had an illness that would manifest in paranoia and erratic. An example of one faulty belief he thought all men who wore red ties were part of the communist conspiracy against him. So as you can see, you can still have schizophrenia and contribute to society and have a meaningful life. There are 5 domains of abnormalities found in these disorders. Delusions, fixed beliefs that are not amenable to change in light of conflicting evidence. So even though logically the person may know and understand that this belief does not make sense, they continue to believe that despite the evidence. Hallucinations are perceived experiences that occur without an external stimulus. So these individuals might hear or feel or smell things that aren't there, so there's no external stimulus from the environment or other people. Disorganized thinking. Thinking is easiest to assess by assessing a person's speech. So when a person has derailment or loose associations, they're switching quickly from one topic to another. If somebody is tangential, the answers to questions may be totally unrelated. Word salad is severely disorganized, nearly incomprehensible, and it's really rare. I've seen it one time out of all the thousands of patients I've seen. Grossly disorganized or abnormal motor behavior. This would include catatonia. And negative symptoms, such as lack of emotion or eye contact. So 5 domains of abnormalities. So let's pause for a minute. If we're thinking about the previous slide, what, as a nurse, would our nursing process entail? So obviously, the individual would be at risk for disturbed sensory perception or injury. They may have a disturbed thought process, there's a risk for violence, and they may have impaired verbal communication. So we want to promote trust, avoid physical contact, avoid laughing and whispering because the individual may think that we're talking about them. We want to encourage one-on-one relationships and maintain an assertive, matter-of-fact, yet genuine approach. We may have to orient them to reality, and we will need to continuously monitor the environment. We need to look for unsafe conditions or hazards and modify those. During assessment, a nurse would look for both subjective and objective data. Characteristics of psychotic disorders include positive symptoms, negative symptoms, cognitive and affective symptoms. Positive symptoms. Positive symptoms are the manifestation of things that are not normally present. So these are pretty easy to identify. They would include hallucinations, delusions, alterations in speech, or bizarre behaviors such as walking backward constantly. Negative symptoms would include the absence of things that are not normally present, and these symptoms are more difficult to treat successfully than positive symptoms. So the individual's affect might be blunted, so a narrow range of normal emotion, or flat facial expression that never changes. They may have poverty of thought or speech, so the client might sit with a visitor but only mumble or respond vaguely. They may experience inertia or lack of energy, anhedonia, lack of pleasure or joy, or avolition, the lack of motivation in activities and hygiene. For example, they might be able to make their bed but could not brush their teeth without being prompted to do so. So let's talk about speech alterations. An individual said to have a flight of ideas would have associative looseness. So the client may talk in complete sentences, but each sentence could relate to another topic, and the listener would be unable to follow the client's thoughts. Neologism means made-up words that would only have meaning to the client, such as a client saying, "Banonkers kinda conkers," and that would have meaning to them, but not to you. And echolalia, the client repeats the words spoken to him. So if you ask the client, did you have a nice day? They would say, "Did you have a nice day?" Clang association, meaningless rhyming of words, often forceful, such as nose, close, toes. Word salad. This is words jumbled together and they have little or no significance to the listener. They may experience disordered thinking. So problems with cognition make it very difficult for the patient to live independently. They may have the inability to make their own decisions or solve problems, difficulty concentrating on a task, and memory deficits. So that could be long-term memory or working memory, like following directions to find an address. Affective symptoms involve emotion, so they may feel hopeless or have suicidal ideations. Alterations in thought, delusions, are fixed false beliefs that cannot be corrected by reasoning and could be quite bizarre. So let's go through these and define what they mean. Idea of reference. So the individual might take a trivial event and attach it to having a personal significance to them. So let's say that an individual sees somebody turn on their turn signal. They might feel that that turn signal has a specific meaning just for them. Persecution. Feels singled out for harm by others. A common theme would be that they're being hunted down by the police or the FBI or the government. Delusion of grandeur means that the person feels really powerful and important. And many times they might even think that they're Jesus or God or they're going to be the next president. Somatic delusions. The individual believes their body is changing in an unusual way. Perhaps they're growing a unicorn horn or a third arm. Jealousy. This individual may feel that his or her spouse is having an affair with another person, and it could be entirely untrue. It could be a thought that they are being controlled by an outside force. Thought broadcasting is when they believe their own thoughts are being heard by everyone else. Thought insertions is when they believe that other people's thoughts are being inserted into their own mind. And thought withdrawal is when they believe their thoughts have been removed from their mind totally by an outside agency. And individuals who have delusions that are religious in nature are obsessed with religious beliefs. So, for example, they might believe if they twirl their arm repeatedly, that God can somehow help them. Individuals with psychotic disorders may experience alterations in perception. So again, hallucinations can be auditory, visual, tactile, or olfactory in nature. And auditory hallucinations can include command hallucinations. And that's when a voice instructs the client to perform an action, like hurting himself or others. There's some evidence that says true command hallucinations are harder actually for the client to hear. Personal boundary difficulties. So the individual may feel disenfranchised from their own body, identity, or perception. So depersonalization is a non-specific feeling that a person has totally lost their own identity. So they feel like they're unreal. Derealization is a perception that the environment is somehow changed. Alterations in behavior. This may include extreme agitation, which includes pacing or rocking, stereotyped behaviors, so motor patterns that had meaning to a client, like vacuuming a floor, are now mechanical and lack purpose. They just do it kind of mindlessly. Automatic obedience, responding in a robot-like manner. Wavy flexibility, excessive maintenance of position. Stupor, motionless for long periods of time, almost coma-like. Negativism, doing the opposite of what is requested, or echopraxia, purposeful imitation of movements made by others. Screening tools that are used include the Global Assessment of Functioning, or GAF scale. This scale helps to determine a client's ability to perform activities of daily living and to function independently. It is appropriate for use with all clients who have a mental health disorder. There's a scale for assessment of negative symptoms, a brief psychiatric rating scale, and an AIMS scale, Abnormal Involuntary Movement Scale. Global Assessment of Functioning. So if we are looking at the screening tool, you can kind of estimate what an individual's global level of functioning is. And sometimes this is used to see if they need assistance with housing or ADLs. So absent or minimal symptoms, like maybe having test anxiety, good functioning in all areas, generally satisfied with life, and maybe an occasional disagreement with a family member, well, your global assessment of functioning would probably be 81 to 90. So that's really high. The higher the number, the better. Let's look at somebody that has a GAF score of, we'll say 45. These people have serious symptoms. They might have suicidal ideation, severe obsession or rituals like shoplifting, serious impairments in social, occupational, or school functioning. So no friends or unable to keep a job. And if we look down towards the bottom, between 21 and 30, those individuals, their behavior is considerably influenced by delusions or hallucinations or serious impairment in communication or judgment. So maybe they have, their thoughts are incoherent, their acts are inappropriate, suicidal preoccupied with suicide, where they're unable to function in most areas. They stay in bed, no job, no home, no friends. So the lower the GAF score, or Global Assessment of Functioning score, the lower level of functioning in an individual. Patient-centered care includes milieu therapy. So milieu therapy for clients who have a psychotic disorder could be in an acute mental health facility or in a community facility, like a residential crisis center, a halfway house, or a day treatment program. We want to provide a structured, safe environment, which is the milieu, the environment, for the client in order to decrease anxiety and to distract the client from constant thinking about hallucinations. Assertive community treatment, or ACT, is intensive case management and interprofessional team approach to assist clients with community living needs. We want to promote therapeutic communication. This helps lower anxiety, decrease defense patterns, and encourages participation in the milieu. We want to establish a trusting relationship with the client, encourage the development of social skills and friendships, and encourage participation in group work and psychoeducation. We have to use appropriate communication to address hallucinations and delusions. So ask the client about the hallucination. Don't argue or agree with the client's view of the situation, but offer a comment like, "I don't hear anything, but you seem to feel frightened." Do not argue with the client's delusions, but focus on the client's feelings and possibly offer a reasonable explanation. You might say something like, "I can't imagine that the CIA would have a reason to want to kill you, but it must be so scary to feel like that's happening." Assess the client for paranoid delusions, which can increase the risk for violence against others. Provide for safety if the client is experiencing command hallucinations due to the increased risk for harm to self or others. Attempt to focus conversations on reality-based subjects. Identify triggers like loud noises and situations that seem to trigger conversations about the client's delusion. Be genuine and empathetic in dealing with the client. So client education. We want to let the client know that they may have case management that would help follow up with them or the family, the importance of going to group, family, or individual psychoeducation classes or psychotherapy to help with problem solving and interpersonal skills, social skills training. So that focuses on social and EDL skills. And we want to do health teaching so that they understand the disorder, the need to self-care to prevent relapse, medication effects, adverse effects, importance of compliance, importance of attending support groups, abstinence from the use of alcohol or drugs, and keeping a log or journal of feelings and changes and behavior to help monitor medication effectiveness. Atypical antipsychotics are medications for psychotic disorders and usually can treat both positive and negative symptoms. So these would include Risperdal, Zyprexa, Seroquel, Geodon, Abilify, or Clozaril. Risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, clozapine. So to minimize weight gain, we want to advise the client to eat a healthy, low-calorie diet and engage in regular exercise and monitor weight, and to look out for symptoms of agitation, dizziness, sedation, and sleep disruption. Instruct the client to report these adverse effects because the client might then need their medication changed. Conventional antipsychotics are mainly used to treat positive psychotic symptoms. So haloperidol or Haldol, loxapine or Loxetine, chlorpromazine or Thorazine, fluphenazine or Prolixin. Antidepressants can be used to treat depression in clients who have psychotic disorder at times. These would include things like fluoxetine or Prozac, escitalopram or Lexapro, paroxetine or Paxil. Also, they may use anti-anxiety or anxiolytic medications, lorazepam or Ativan, and clonazepam or Klonopin. With antidepressants, these would usually be used temporarily to treat depression. We want to monitor them for suicidal ideation because the medication can increase thoughts of self-harm, especially when they started. Notify their provider right away if anything like that occurs, if depression gets worse, and advise them to avoid abruptly ending any medication to avoid withdrawal effects. For anxiolytics, we want to inform the client of the medication's sedative effects. It says that we may need to inform the client of the need for blood tests to monitor for granulocytosis in your book. That would be true for other medications. And these medications are used with caution in older adult clients. Also, when mixed with alcohol or opioids, they can cause death.